Dr. Bertrand Tombol, chairman of the GUCG and EORTC, can you explain why we should rethink the clinical trial landscape?
But I think there are three reasons. The first one is that if you look at our guidelines, we have beautiful guidelines at EAU. Actually, if we dig into these guidelines, we realize that many things we do are not based on high level of evidence, but much more of what I like to call conventional wisdom, meaning that is acceptable. So we need to increase the level of evidence. The second is that we have no multiple treatment option, we have no multiple drugs, multiple therapeutics, and really we will not be able to afford all of this. And we're going to have to be better in individualizing the treatments, what oncologists like to call tailored therapy. This is something we don't do in urology. If you have a breast cancer, they're going to look at your cancer and really, they're going to really straighten the treatment to what you need. We don't do that, so we need to do this, absolutely. And the third one is that as a community, we need to grow to a larger group of physicians who really look at these questions. So I believe this is the whole landscape we have to reshape.
Could you summarize the challenges for the urological oncology and the academic medicine?
I think for the uro-oncologist, the challenge are really first, how do you live in a multi-professional environment? We have been trained as doing everything in our own specialty. I would like to say from crib to grave, but it has changed now. I mean, we have to work with many other specialists, so we have to leave for this. That's the first one. The second, we have to face all the economic involved into running a department. Basically, my boss doesn't like when I do clinical trials because it does not produce a lot of money. And the third challenge is really, how are we going to raise a new generation of people that are interested into that job? So these are three important challenges.
You mentioned that fewer patients should be included into clinical trials and that research should be more incorporated with standard treatment. Could you elaborate on that?
So clearly one of the problems in urology is that we have a very heterogeneous population. So let's take an example. You want to do a trial in rising PSA patient, for instance. You're going to have to take a large number of patients because the drug you will use will only benefit a few percentage of these patients. Therefore, I believe we should work with screening platforms. So first, recognize the heterogeneity. Therefore, we will narrow the population of patients. And if you have narrowed the population to a group of patients that are more likely to benefit from your drug, then you may do the same trial with the same question on a more restricted population. That's what I mean. I don't mean that we should just reduce the number of patients. No, we have to enrich the patient population with patients that I would call likely responder, patients that are likely to benefit, so that we can see a response on a limited number of patients.
Isn't it a problem that results of these observational studies are less reliable?
It depends. The problem of observational studies is that usually they are retrospective, meaning that the way you look at the patient was not decided upfront. If you start running observational platform where you have agreed on how you look at the patient, what kind of measurement you do, what kind of quality insurance you have in the data collection and data reporting, then you make the information coming from observational platform extremely valuable. The problem is not the observation itself. The problem is really the quality of the data, the quality of the surgery. For instance, let's take an example. The role of extended lymph node dissection in prostate cancer. If you go back and look at historical data, you may have answer, but basically you don't know how the lymph node dissection was done. If you say no, starting from now, we're going to do the operation, everybody the same way, we're going to record the quality of the surgery, we're going to put some standard in the way we do the lymph node dissection. Then you are creating something that is powerful because basically, even if it's observational, the consolidation has been done and you produce a very high quality data.
Thank you very much.
You're welcome.